let's go ahead with the afternoon session. We're going to start with the keynote lectures on TAVR 2024. Alan Yeung and Dr. Park. We have Dr. Bapat, Dr. Chae, Dr. Cohen, Dr. Grube, Dr. Hayashida, Dr. Kim, Dr. Park, and Dr. Poon.
How does it work?
And the first is actually Eberhard. We're going to talk about TAVR 2024. What do we know and what is still missing?
Great. Can I go now?
Yeah.
Okay, so TAVR 2024. The title was Do We Know What Is Missing and What Do We Need to Know? My disclosures. We know and I would like to start with some general remarks because you know the Rumsfeldian thinking, known knowns, known unknowns, and unknowns unknowns. So let's start with the known knowns. Today, TAVR is becoming mainstream therapy, saving lives and improving non-surgical quality of life. TAVR gave birth to structural heart interventions. The trends of aortic valve replacement in the US, I would like to point out US. This is not true for Europe. You can see TAVR is increasing, surgery slightly decreasing. And what's interesting, on the right side, you can see TAVR is increasing in all age groups. If you look to the left, even in the age group less than 65, TAVR is increasing and surgery is decreasing. That is not the case in Europe. Time doesn't allow to show you details, but I just want to point that out. We have an expected growth until 2030 of about 300% of TAVR procedures. A very important slide here, improve patient selection and disease awareness. We all know that for any disease that we are treating with TAVR, we probably have to tackle and to look at patients earlier than we did in the past. 30% of patients undergoing TAVR derive minimal symptom benefit or die within 1 year. So clearly, disease awareness and individual patient outcomes comes into focus. The impact of 1-year changes in cardiac damage on clinical course is clear. In severe aortic stenosis, waiting for symptoms as the main trigger for replacement results in more damage, which is not reversible in most patients after replacement and predicts long-term adverse clinical outcomes. What have we learned? If we compare the two, similar late outcomes in all-cause mortality and stroke between the two, higher rates with surgery, atrial fibrillation, bleeding complications, renal injury, better with TAVR, higher rates with TAVR, permanent pacemakers, and paravalvular regurgitation. Competing risks, obviously, shared decision-making, the heart team is the way to go, I think, in today's world in all geographies. But now coming to the known unknowns. Evidence gaps are summarized here. We don't have time to go through all of them, but I would like to point out a few that I would like to address. Lifetime management, durability, hemodynamics gradients, TAVR and PPM, valve thrombosis, redo TAVR, coronary access, bicuspid valve disease, aortic insufficiency, moderate aortic stenosis. So what means durability and how is it defined? We know it is a multifactorial issue with impacts on expected valves in the long term. An ideal THV should replicate a healthy aortic valve going through 40 million cycles per year with unfaltering function. That's what we'd like to expect, and that's what we'd like to see. We try to ensure durability by continued trial follow-up, engineering and bench testing, new repositionable systems, and continued advancement such as advanced steering, torqueability, depth control, and low-profile materials. Questions to be asked today: results of surgery versus TAVR trials, particularly looking at the long-term results. Are all THVs created equal? Does THV design matter in outcomes? Is there a THV class effect in TAVR? What is the significance of PPM? Does only severe PPM matter? And should we look for and treat valve thrombosis? And if yes, how? And does subclinical leaflet thrombosis triggers SVD or BVF? So let's start with bioprosthetic valve dysfunction, structural valve deterioration. TAVR versus surgery, short and long-term results. We know these results, but I could not resist giving you some update on the New England Journal of the Dedicate trial. And you can see that was not sponsored by industry. It was a real-world setting and unrestricted access to several contemporary transcatheter heart valve devices. Good news for TAVR. Continuously increasing gap in the Kaplan-Meier curves, as shown here, death, stroke at any cause, and then larger valves in the TAVR cohort compared to surgery, improved valve area and dyspnea in the TAVR cohort. So good news in the latest New England Journal of Medicine. Longest follow-up of landmark trials, Partner 3 in Evolute low risk. We know that low-risk trials showed non-inferiority in Partner 3 or superiority, Evolute low risk, for TAVR compared to surgery if we look at SVD and BVF. Good news are summarized here. SVD 1.3% and BVF 3.7% across the board. Are all THVs created equal? Does THV design matter, and is there a class effect? We would like to see with any THV low rates of SVD, low rates of PPM, and low rates of thrombosis. That should be the goal, and we will see whether that's true. Now, does frame design or THV design matter? I believe it does. This is an example of the Evolute, but I could show others. THV design does matter and may account for differences in hemodynamics and gradients, as well as early and late outcomes and durability. We also have those data, as you all know. TAVR has revolutionized the treatment of patients with severe aortic stenosis, which has become the dominant therapy in all patients except the very young. Similar to surgical valves, TAVR valves have varying designs and performance metrics. We can no longer consider TAVR a class effect. Linking THV performance to late clinical outcomes is essential to understand the value of THV in younger patients. Do new valve designs improve durability and outcome? Let me summarize, only time will tell. This is an interesting design, the Anteris Duravad bioprosthetic valve. It does have specifics, laminar flow. Sushil has published very interesting early data. Whether that conveys to better durability, only time will tell. But interesting, and it is normalizing the flow and comparing it to the normal aortic valve. The Siegel THV design is another interesting new design, a new valve. It has a new rhenium frame, nickel-free, which is a specific metal that has some advantages over chromium and nitro and nickel. Time doesn't allow to go into details, but it is delivered on crimped. It's an 8 French expandable sheath, so it might have potential advantages both by design and by metal, and by access due to the low sheath size. And then, of course, the Foldex valve. It's a polymer valve with robotic manufacturing. The mitral surgical valve is being implanted in India, and the Triad TAVR systems are underway. The robotic manufacturing is actually an interesting highly precise reproducible processes with minimal human handling required, no labor-intensive hand sewing, and small, efficient robotic pods can produce valves in geographies. Then non-valve structure valve deterioration, the conundrum with patient-prosthesis mismatch in TAVR clinical studies. Severe PPM in the TVT registry has been predictive for late mortality for both balloon and self-expandable valves. However, an analysis of the same TVT registry found by Dr. Tang and his co-workers, PPM did not identify, was not a predictor of mortality, and that other factors related to patient comorbidity were more predictive of mortality. So there's a controversy because in the Partner 3 study, severe PPM was indeed an important predictor of death, stroke, and rehospitalization. This is summarized on this slide, the conundrum. Here you can see on the left side, severe PPM does impact mortality. In the middle, severe PPM does not impact mortality. And on the right side, severe PPM, which is clear, impacts clinical events. So the controversies in establishing appropriate PPM criteria are underway, and there are reasons why reported incidence of PPN varies after TAVR and why the effects of severe PPM on outcomes are conflicting. Next, thrombosis. We do know that thrombus formation may lead to basal leaflet calcification. What is known, what is new, and what is still unknown? On the right side, regarding valve thrombosis, impact on valve durability, impact on clinical outcomes, role of routine CT screening, difference of SLT in different valve types, role of routine anticoagulation in young and low-risk patients, cerebral events with SLT, predictors of progression, resolution, persistence or recurrence, and of course the impact of hypercoagulability. Now TAVR and TAVR, redo TAVR, we've seen a lot. You know also this slide, which will basically tell you there will be a TAV and TAV wave coming up, and we have to prepare for this. We have discussed this morning. The decision-making process for valve and valve procedures is clear. Patient selection, the type of failed valves, mechanism of failure, pre-procedural planning, THV dimensions, risk of coronary obstruction, and then, of course, the procedure itself, the THV selection, and procedural planning. What else is important in redo TAVR? Neoskirt considerations, leaflet overhang, and index THV expansion. We try to do, when we do redo TAVR, avoid high gradients and coronary obstruction, conceptual interaction with SAPIEN 3 and with Evolute. We know the lowest risk of coronary flow obstruction, highest likelihood of coronary accessibility, and lowest gradient occurs with S3 outflow at Evolute node 4. The other thing is for coronary obstruction, avoiding coronary obstruction, the decision, should we do basilica, classic basilica, or BA basilica? And then also, how much modification is needed? What's the risk? What's the benefit between laceration and leaflet resection? Bicuspid aortic valve disease, and here we're coming to one of the important centers in Asia, ASEAN data. Do we still have data gaps? Yes, I think we do. We do know what is suitable for TAVR, and we do know what's not so good for TAVR. We all know that. We also know what we know, the warning, and the remaining questions. Most importantly, do we need a randomized controlled trial? We all know now. 2 trials are underway, the Navigate bicuspid trial, run by Dr. Windecker and his co-workers, and the Believers trial from Raj Makkar and Vinod Turani, patients with severe bicuspid aortic valve stenosis, more than 50-year-old, TAVR versus surgery. Time will tell. But there's a lot more we don't know, and I'm not sure whether we're on the right track, particularly looking at optimal sizing methodology for BAV TAVR, and really is CVER's classification still up to date, and should this be the classification that we need? In fact, bicuspid aortic valve disease is a very, very complex entity, and others have suggested more definitive and more detailed classifications than CVER's. Then finally, the conundrum of asymptomatic and moderate aortic stenosis, and why are we targeting them? Basically, this is why. Looking both at mild aortic stenosis and mild to moderate and moderate aortic stenosis, there's a huge discrepancy between 4-year treatment rates and 4-year mortality rates, as shown here, even in mild aortic stenosis. Watchful waiting is ingrained in clinical practice. We all know this until we have further data. However, we also know that moderate aortic stenosis is not a design disease, that moderate should be or could be as bad as severe aortic stenosis. Upcoming trials for asymptomatic and moderate aortic stenosis, the early TAVR trial, which will be a late breaker at TCT 2024, the EVOLVE trial, earlier aortic valve replacement with biomarker screening, also a late breaker at TCT 2024, And those are the trials in moderate aortic stenosis, and one of them, the TAVR Unload, is a late breaker at TCT 2024. My last slide. In today's fast-changing, turbulent world, it is hard to predict the next year, not to speak about 10 years. However, the future of medicine, and specifically of structural heart, is not something to predict. It is something to build. This very year, at the 22nd anniversary of TAVR, we can look back with pride and astonishment and implement the experience we built to the existing unmet needs, driving innovative therapeutic solutions forward. With that, I'd like to close. Thank you and be safe.
Maybe we can have the discussion at the end. So the next lecturer is Vinayak Bapat. He's going to talk about redo TAVR, TAV and TAV, understanding complexity, common terminology, and the use of the app.
Thank you very much, Alan. Thank you for this opportunity. I think as you see that as we start using TAVR in younger patients or patients with longer life expectancy, failure is going to be quite common. So these are my disclosures. So first of all, what we learned from valve-in-valve. One important thing or major differences, as you can see, that surgical valves are implanted usually at the annulus level. Most valves, irrespective of the design, have the same height. And more importantly, when we take the valve out of the box and we suture it inside, the dimensions are maintained, what we call as true ID. So the TAVR designs, however, are very different. And the way we implant is the depth can vary. It could be as deep as 8 millimeters, or it could be as high as 0 millimeters. All the TAVR designs are different. That means the height, the leaflet design, the stent frames are different. And more importantly, and probably the most important thing, is the dimensions when we take it out of the box is very different than the dimensions in the patient. And we have published actually quite a lot on that. So the CT planning is going to be literally critical in my mind for this particular topic, while for valve-in-valve, most of the time we can predict it without CT. So these are the two cases in my center. Both look pretty quick and similar. One is sapien in evolute, other is evolute in sapien. They look really straightforward and simple, but I can tell you one patient had a life-threatening problem while the other patient went home without any issue. We were quite ignorant that time why this happened, not very different. So what are the important considerations? So first of all, the important thing we have to understand is which second TAV we can use. And the reason I say that is every TAV is not compatible in another TAV. What size of the TAV we are going to use is going to be really important. Prevent coronary obstruction, and sometimes in younger patients, maintain coronary access is also important. And finally, let's not forget that fixation and function are two important things why we do any procedure. So we have to make sure not only all the above three are good, but the function is also good at the end of the procedure. So there are some key concepts, and the reason to float these concepts here is the reports are going to kind of say these new terminologies, such as coronary risk plane, neo-skirt plane, different distances to calculate, the risk of coronaries. What are the sizing levels and what are the positioning levels as well for each TAVR device? And why do I say that? I'm just going to give you a couple of examples. This is the SAPIEN 3 in all its variations. We need to understand how under fluoroscopy and CT, what the important landmarks are going to be. We need to know where the neo-skirt plane for a SAPIEN 3 is going to be, and that's going to give us important information about risk to coronaries as well and sizing. So for example, SAPIEN, we always refer to as top of the commissure tab. And this is where the leaflets, when they're pinned open, are going to end up. So that's the height of the neo-skirt. But if we are addressing evolute R, we are not going to talk about top of the commissure tab, but we are going to talk of different nodes. So again, slightly different, but very specific to this valve. While if it's accurate, then we are going to talk of different landmarks completely. So very important when you are looking at a valve which is failed, you have to understand the first valve properly and just align yourself with these landmarks. The second thing is, where is the coronary risk plane? And for safety reason at present, because this is a very new topic, we define this plane at the bottom of the lowest coronary. So for example, let's take these three evolute Rs, which are implanted at maybe different depths, or the coronary heights are different. As you can see, that coronary risk plane on the left side is node 3, while on the middle is node 4, and the right side is node 5. This is, again, very important when you are analyzing the risk when you are implanting another device into these valves. This is going to be different for SAPIEN. We are just going to say above the commissure tab or below the commissure tab. Then for simplicity, you go to any session and people suddenly start talking about SAPIEN in SAPIEN, then they jump onto accurate in SAPIEN, and then evolute in something else, and it all gets very confusing. So important thing is there are 4 combinations, and you can see that these are the 4 combinations possible in redo TAV, out of which the left side 3 are slightly simple to understand. The one which is the short in a tall is adjustable, and I'm going to quickly show you what I mean by that. So let's look at the neo-skirt plane, and this is important in analyzing coronary risk. If you implant another valve inside, the leaflets spin open to the maximum height. So you can't really change it. This is how it's going to be, whether we like it or not. So for example, short in short is going to be top of the commissure tab. Tall in tall is going to be node 6 or node 7. And short in tall is roughly going to be the height of the SAPIEN itself. But when you come to a short in a tall, you can adjust it a bit. And what I mean by that is, here you can implant it at node 6, and you have minimum leaflet overhang, around 7 to 8%. If you can go to node 5, you get around 30% leaflet overhang, or 16%, I think. And then when you go to node 4, you get around 32% leaflet overhang. Now, you can't implant below node 4, because then you're not treating the aortic stenosis valve. You can only do it in life-threatening situations if there's aortic regurg. And I think you need to understand that you have to pin open the leaflets. But as you go lower, the leaflet overhang is more. So we need to understand the implications in future. So even in SAPIEN, we have now done cases where it's a very high-risk patient, and if I implant it really properly, that is top of commissure tab, is going to cause some problem. So we can implant a bit lower as well. And this gives you that 2 millimeter or 3 to access the coronary if there is an issue. So just keep that in mind. While tall and short, you can actually, by mistake, implant higher, and this will increase the neoskirt. So please don't do that. It's not necessary for hemodynamics. So very important again. Now, this is an equation which still we don't understand fully, is how low can you implant a short valve in a tall valve? And, but most important thing I know as a doctor, and I think you all will agree, that we don't want any coronary problem on the table. Because if you have that, usually it means a catastrophic problem, death, or complex procedures such as ECMO, chimney stent, and blah, blah, blah. So I think the most important thing is to accept maybe in some patients lower hemodynamics, but maintain coronary perfusion. I think this should be high on the agenda. So this is what we are studying at present in terms of what are the geometric opening areas on the bench, and Stephanie Sellers presented the node 5 implant, but we are also now conducting experiments on node 4 implant. And if my area B, which is the top area, is bigger than area A, I think we should be good for at least hemodynamics, and that's the concept. Sizing is very important, and don't get me wrong, we are still learning about it. I'm going to show you why. This is what happens in vivo, and my group has published enough on this, on SAPIEN as well as Evolute, and we'll be soon publishing data on Accurate as well as Portico. So what is important is we can't just say this is a 23S3, so just use those dimensions. We need to definitely see in vivo dimensions. So currently we use the combination of 3 for SAPIEN, but my gut feeling is the narrowest diameter which is going to determine what we implant. And unfortunately now, as you saw the case Kentaro showed, all the new SAPIENs have a skirt outside. So that's going to actually reduce 1 millimeter or 1.5 millimeter margin. So maybe in future we'll get SAPIEN without any skirt for this particular indication. For Evolute R, we advise people to measure 4 nodes. So for example, if you are analyzing at node 6, you should take 6, 5, 4, 3 and do an average. And it has worked very, very well in clinical practice now. More than 100 cases have been done. For example, here, just to highlight that if you lower the node in 23 and 26 evolute, the size usually doesn't change. But for size 34, if you go down, the size of the sapien may become bigger. So very important, again, to understand the nuances of different. And for evolute, I advise everybody to do the analysis for all 3 levels and then choose what is the best for your case, rather than just analyzing one level. For accurate, again, there are 2 implant positions. One is below the commissure tab and one is at top of the upper crown. What we have learned in clinical practice. So these are not just hypothetical numbers which I'm throwing at everybody, but we have actually applied this prospectively as well. And what we have seen is very, very interesting. So I'm just going to show you early example. This is where we had a evolute 26. The bench size on, Janar has published quite a lot, is Sapien 323. And you can see that when we measured the expansion of the sapien, it was very, very underexpanded. And, on table, this is okay, but I can tell you that you do the CT after 1 year, these patients have halt by default. So we don't necessarily want that. So what we do now is we do actually in vivo sizing, as I mentioned, and what we have found is actually the expansion of the second valve is much better. And I think these algorithms are going to be important for all the redo TAVR registries which are running in Europe as well as soon to be started in US as well. So a lot of new things to digest in terms of this. And finally, but most importantly, is coronary risk. And what we do currently at present is we do the analysis if the neoskirt plane is above the coronary risk plane. That means when you implant it, you're going to cause some risk to the coronary. Just to give you a very neat example, to be honest, whenever some evolutars come or sapiens come which are implanted deep, I'm very happy because the risk to coronary with the second procedure is very low. However, when you are implanting 0, 1 millimeter, at least 30% of patients are not going to be suitable or they are going to be more challenging. So as you can see here, you can see the different implant positions and when you need to do the analysis. We ask people to measure multiple dimensions. In valve, we only measure VTC because most surgical valves are below ST junction. But in TAVR, neoskirt plane can be above ST junction, and it's the narrowest area. It has happened in my center that the VTC distance was actually 4 and 6, but in that sapien, our VT-STJ would have been 0. And that patient went actually for explant rather than for a redo TAV for the right reason. And I think this is very important to pay attention and then go to the narrowest area. And we currently give you a cautious classification. This is not a rule set in stone, but anything which is yellow or red, I think you need to pay more attention and think of more things such as coronary protection, etc. Lastly, but not least, is most of the time the CT analysis is done today, and then we do the procedure a few days later, and that's very common. So how do we remember all this? And I think in the app, we give that visual summary, which is device-specific and combination-specific. Very, very important to understand this, that device and combination-specific analysis is very important. And with respect to time, I'm just going to quickly run through this. This is just an example of a failed evolute, shows at different levels we have measured. There are, step-by-step guide in the app. You enter all the areas and perimeter. It allows you to select the second valve, and it also tells you the different levels you can implant. If this was a sapien failed, it would tell you only one level to implant. Here we have chosen 26. And when we did the analysis, you can see that although the ideal is node 6, here, needless to say, I chose node 5. Because at node 5, the risk to coronary is none. And I want a good combination, compromise between hemodynamic and coronary analysis. So again, I think we need to analyze at different levels, spend a bit more time, and then do the procedure. And finally, you can take this report to your cath lab. So you take a screenshot, and 3-Mensio, you can import it in that, because then at the time of the procedure, you have a good visual summary of all the dimensions which are there and how you're going to position, etc. And this is just 3 pages of summary report. And finally, for the procedure guide, it tells you very importantly how to position the valve, because this can be very tricky as well. We do advise people to put a coronary guide just to give you an idea of where the coronary is. And slow inflation has been really critical in implanting and success of this procedure. So just to show you, depending upon different combinations, my team has done an amazing job at creating more than 2,000 images, which are combination and level specific. And if you are really interested, you should use this post-procedure outcome data. This is going to be very important for future registries in different regions. This really captures the essence of what we do every day in the lab, which is nearly forgotten, and after 1 month, you can't get that. Lastly, but not the least, there are many other features in the app as well. And you click on this black button, you get how to analyze each combination. There are all the combinations possible in the world. You can print the charts out, and you can keep them in the office. So I'll, again, thank you for the opportunity, and hopefully you find this useful. Thank you.
Okay, move on. Next talk, about TAVR in Asia, optimal TAVR choice for Asian patient with a small annulus, vessels, and body size.
Thank you. So my topic is about the TAVR procedure in the Asian population. So, and there are substantial racial disparity in the TAVR procedure. And this is a very well-written review article, and I and Kentaro Hayashida is a co-corresponding author, and published in JAG Asia. One of the key different features in the compared to Western to Asian is, as everybody know well, and has a smaller annulus area and a smaller vessel, and the reason why we should more frequently select a smaller device size. And also, and looking at the published data and the small annulus, and the much higher in the Asian people is 60%, was you should use the small annulus. And the racial difference concern in TAVR procedure, and the small annulus has an impact on PPM and structural valve degeneration, long-term durability. And theoretically, small annulus is a higher leaflet mechanical strength, and this is a main determinant of structural valve degeneration. And also, a small annulus could be associated higher risk of the PPM. And issue 1 is PPM prosthesis patient mismatch could be more relevant in Asian population. This is a well-known published data, and the STS-TVT PPM itself compared with the PPM associated higher long-term mortality. And this is different data in TP-TAVR registry combining ASEAN, Stanford, Northwestern, including Asian and Western population. And compared to the Western population, BMI, BSA, substantially low, and the BSA is an important main driver of incidence PPM. And beyond our initial expectation, overall incidence of moderate red color, severe blue color PPM was much higher in the Western population compared to the Asian population. And contradicted to the TVT registry, we didn't find any impact of a PPM and the composite of death, stroke, rehospitalization, even though a follow-up period is relatively short, up to 1 year. And the issue is about the long-term durability. In the use of a smaller TAVR valve, it could be associated with less favorable long-term durability, and the valve TAVR with a larger EOA always beneficial for Asian population with a small annulus. That could be issue. And this is a 5-year outcome of the Partner 3 trial. One of the interesting key slide about the primary endpoint, all-cause death, stroke, rehospitalization. Absolutely same in the SAPIEN small, 23, 26, and 29. all-cause mortality, we didn't find any different finding. This is partner 3 result up to 5 years. And the SMART trial we talked too much about, and this is targeting the small annulus and the area less than 430, and implanted Eberhard versus Sapien valve. And the primary endpoint was the 2 primary endpoints. One is the hard endpoint, the death, stroke, rehospitalization. This is the same in the partner 3 trial. Second trial is combining functional endpoint, hemodynamic valve degeneration, non-structural valve dysfunction, and thrombosis and endocarditis. Looking at the box 3 definition, valve dysfunction, this trial adapted and the severe hemodynamic valve dysfunction, mean pressure gradient more than 20, also non-structural valve dysfunction, and the ppm ratio, and clinical relevant thrombosis, and the incidence of endocarditis. And looking at the procedure, 23 Sapien Eberhard is the most frequently used, and the Sapien is 23 and most frequently used. And the overall, the size is something like this. And the primary endpoint, the hard clinical endpoints, no difference at all between 2 groups. And the valve is, the Sapien valve and the Eberhard valve is nearly same. And the key secondary endpoint, the bioprosthetic valve dysfunction, and the substantially higher with the Sapien valve main region is a hemodynamic structural valve degeneration that is driven by pressure gradient more than 20, is approximately more than 10 times. And the non-structural valve degeneration, and that means the ppm incidence is more than 3 times. That is the main driver, big difference of the co-primary endpoint. And as expected, hemodynamics much better with the Eberhard system, and the EUA much bigger, pressure gradient much lower with the Eberhard system compared to the Sapien valve. And all the secondary hemodynamics much better, Eberhard system, mean gradient, EUA, hemodynamic structure valve, and the moderate severe ppm. So quality of life, and because of some larger EUA, symptom improvement much higher in the self-expandable 75% and the balloon expandable 68%. So SMART trial showing the non-inferior, the hard endpoint, superior in soft endpoint based on hemodynamics, and this difference and self-expandable demonstrate improved valve durability and outcome during long-term follow-up. So, and we should consider SMART trial impact in OCEAN-TAVI recipient and the SMART versus partner 3 long-term, similar finding in hard endpoint, but better outcome with the soft endpoint, and there is a bioprosthetic dysfunction, mainly driven by mean pressure gradient and the overall incidence of the ppm. Hemodynamic structural valve deterioration also included the asymptomatic, isolated hemodynamic dysfunction, even without evidence of morphological structural valve degeneration. Clinical applicability we should consider, and the SMART trial should be strongly applied for optimal valve selection for Asian population with a small annulus size that could be better. And summary, and the interracial difference in TAVR, there are substantial interracial difference, anatomy, and the patient risk. Small annulus, much common in Asian population compared to the Western population. Direct applicability SMART trial would be still controversial in Asian patients with a small annulus. In clinical viewpoint, it should be further validated. Use of the largest prosthesis based on annulus area perimeter with a better hemodynamic performance is always associated better long-term durability and relevant clinical outcome. My last slide, last question. Does the SMART trial say supraannular self-expanding valve are best in Asian patients with a small annulus? Yes, would be Medtronic. No, would be Edward. Yes, would be Eberhard Grube. No, would be Alan Yeung.
That's good.
Thank you for your attention.
All right, we're gonna move. Kentaro Hayashida will give us the current state of TAVI in Japan, the OCEAN-TAVI Registry. Please.
Okay, thank you very much, ladies and gentlemen. So today I'm going to talk about the current status of TAVI in Japan from the OCEAN-TAVI Registry. And this is my disclosure. So actually, I was trained in France from 2009 to 2012. And at that time, the last year, so we had the two Japanese fellows, the Masa Yamamoto and the Yusuke Watanabe, and we conducted some study using the French data. However, so we need to publish the data from Asia. That's the reason why we studied the Ocean SHE family. And we studied the 4 centers, and you can see the Dr. Shinichi Shirai and everyone from 2014. And we grew up year by year, and this is the 25 centers. And now we reached to the 29 centers with more than 300 members from the north to the south of Japan, and including the more than 22,000 TAVIs and more than 4,000 of the mitral clips until the end of last year. And luckily, we published the more than 100 papers so far, and it reached more than 120 papers, including not only TAVI, but also including the mitral and appendage closure. And some papers are accepted in the guidelines like Japanese and the US and European guidelines. And I'd like to introduce some important studies, and this is a study on the prosthesis-patient mismatch. And notably, severe prosthesis-patient mismatch was noted in only 0.7%. That is much lower than that of the 12% of the United States. Presumably due to the less obese patient in our Japanese patient, and the mean body surface area is much smaller than that of US. That is the reason why we have very low incidence of severe prosthesis patient mismatch in our cohort. And leaflet thrombosis is also quite important topic, and we also published the data from our OCEAN-TAVI registry and in 2019. And leaflet thrombosis didn't impact the prognosis in short-term follow-up. And we also conducted some studies comparing the DOAC and the warfarin after TAVI with the atrial fibrillation. And DOAC did better than warfarin in our registry that is published by my good friend Yusuke Watanabe. And we are the part of the EMPHASIS TAVI AF trial, and this study compared the edoxaban and the warfarin. And edoxaban was not inferior to warfarin. That means that we can also apply this DOAC to the patient with the TAVI and atrial fibrillation. And we also compared the clopidogrel and aspirin when the patient receives only a single antiplatelet therapy, and regardless of the requirement for the anticoagulation or not. And clopidogrel was better than aspirin in our cohort, and this result should be confirmed by the randomized control trial. I've heard that the Korean friends are conducting the randomized control trial on this topic. And sometimes the patient cannot receive any antithrombotic therapy because of the high bleeding risk. And we identified 80% of the patient that didn't receive any antithrombotic therapy after TAVI procedure. However, we named this the no antithrombotic therapy, that's NAPT, and NAPT was associated with less risk of the bleeding and no increase of the thrombotic event. And our hypothesis is that maybe we don't need the antiplatelet therapy after the TAVI procedure. So therefore, now we're conducting the randomized control trial comparing no antiplatelet therapy and aspirin. And we already finished the enrollment of this study, and now we are waiting for the result. And these three devices are currently available in our country: S3UR, Evolute FX, and Navigator Vision. And as already presented, and my good friend Masa Yamamoto demonstrated the better hemodynamic performance of S3UR compared to S3. And notably, the incidence of severe prosthesis mismatch was only noted in 0.5%. That is much better than that of the S3. And this is the table representing our top 11 cited paper from our OCEAN-TAVI registry. The first one is the paper on the clinical frailty scale that is published in Circulation in 2017. And this paper was cited by 40 times per year. And the second one is the leafless thrombosis that is accepted in ejaculation. We also have some paper about the prosthesis patient mismatch as well as the coronary protection and DOAC. So nowadays we have the very stable procedure of TAVI procedure. And MitraClip G4 was also approved in our country from 2020. And we published some 30-day outcome as well as the 1-year outcome. If we leave the MR higher than or equal to grade 2, it was associated with the reduced mortality, reduced survival after procedure. Therefore, we cannot accept the residual moderate PVL, moderate MR. And we also published data about the appendage closure, especially in the cohort of the very elderly cohort. The bleeding risk will be increased, so therefore we need to be careful. And natural history of moderate aortic stenosis is known as very bad. And we are quite happy to be the part of the PROGRESS trial. So maybe 4 or 5 centers are included from our country. And for the TR treatment, TriClip is the indicated, and we finished the clinical trial in our country as well. And you saw the live demonstration of the EVOKE valve from Cedars-Sinai. So you think that it's great, and we also think that it's great. And we have already finished the clinical trial in our country. And very luckily, we conducted the very first case of the EVOKE valve in our country. And we finished 17 cases in our hospital, and the result is so good. So hopefully in the future, it will be approved in our country as well. And you're most welcome to come over to our PCR Tokyo valve that will be held from the during the February 6th to 8th next year. So please come and join us. Thank you very much for your attention.
Okay, so the last talk is going to be by David Cohen, Innovation in TAVR. What can we expect for the next decade?
Thank you very much. This was supposed to be yesterday. There will be some overlap with Dr. Grube, who stole all my slides. So we will see if I say anything different than Eberhard. These are my disclosures, and I want to again thank SJ, DW, and the whole team here for inviting me back this year. So I'm going to talk about 3 things. There are many more that I could talk about, but I wanted to be able to dive in a little more detail than Eberhard had a chance to. So one, I want to talk about treatment of aortic regurgitation. The second is I want to talk about evolution and leaflet modification techniques. And then the third, I want to, again, spend a little bit of time talking about new leaflet and new valve designs. So aortic regurgitation is the next frontier for TAVR, certainly in the United States. And what we are seeing now, we are on the cusp of several approvals, hopefully, of dedicated TAVR systems for aortic regurgitation. This is more of a problem, frankly, in Asia than it is in the United States. But in the United States, moderate and severe aortic regurgitation is common, and severe aortic regurgitation is bad, with a mortality of severe AR untreated is about 10% per year, and it's about 25% per year when the patients have significant symptoms. But it's very undertreated. Fewer than 25% of all patients with severe symptomatic AR undergo surgery. And what we are doing right now in the United States, as we saw from Dr. McCarr this morning, is off-label use of approved devices, which is fine if that's all you've got. But there are relatively high rates of embolization and paravalvular regurgitation, even with the newer generation devices. And so this is the unmet need. The first device that is coming to the market in the United States, and I hope will be also available in Asia, is the Trilogy valve from Jena Valve, which is now part of Edwards as of last week, I think. And the idea here is that it has these alignment tabs that allow you to then grip onto the native leaflets. So even when there's no calcium, you have something to anchor on. And then a very, very reliable deployment with a very accurate depth control because, again, you are prevented from going too deep by these locators that lie in the coronary cusps. This was studied in a single-arm trial called ALIGN-AR of patients with 3+ or greater aortic regurgitation who are at high risk for surgery. And right now we have the 1-year data that have been presented and published in the Lancet earlier this year and are the basis for what we hope will be FDA approval in the United States. The primary safety endpoint here was a composite of all the short-term bad things that can happen, including death, stroke, life-threatening and major bleeding, vascular complications, and new pacemakers. There was a pre-specified non-inferiority margin that was derived from the published literature. You can see that the rate of this safety endpoint was 26.7%, but it was below the agreed-upon threshold for FDA approval. More important to me is the primary efficacy endpoint, which again, based on data from the literature on untreated aortic regurgitation, they needed to beat a 25% 1-year mortality, and you can see here the observed 1-year mortality with treatment was just 7.8% with an upper confidence bound of 12%, so well below the performance goal. So again, achieving both of its primary endpoints. In terms of the hemodynamics, they were really excellent. You can see here again the gradients are in the low single digits with this intraannular device. Paravalvular regurgitation was also excellent with very, very little, anything more than mild, and about 90 to 95% of the patients having none to trace paravalvular regurgitation. And then finally, the patients actually felt quite a bit better. This is the Kansas City Cardiomyopathy Questionnaire. They started out about 55, which is really where typical intermediate risk TAVR lies, went up to about 77, which is again a very substantial gain of more than 20 points per patient. There are other devices coming. This is the J valve, which is also a self-expanding nitinol device that is purpose-built for aortic regurgitation. This is from China, and again, as of last week, this is now part of Edwards. So Edwards is going to have 2 different devices for treatment of aortic regurgitation. This is a little bit earlier in its development. One of the major advantages of the J valve compared to the Jena valve, at least right now, is it has larger sizes, that it can treat larger annuli, which was a major issue with enrollment in the original ALIGN-AR trial. The early feasibility study has been completed in the United States, and a pivotal trial is expected to start sometime later this year in the United States with a very similar design to the ALIGN-AR trial. Shifting gears now to leaflet modification. So we heard from Eberhard a little bit about this. We heard from Vinny about all of the challenges that we have to meet when doing TAV and TAV and TAV and especially with the risk of coronary occlusion, and this has led to the development of leaflet modification. Eberhard already showed this graph. This is projections, a mathematical model that Philippe Genera and some other folks developed, showing what is the projected rate of TAV and TAV, and you can see that their projections are we'll be doing more TAV and TAV procedures than TAV and SAV procedures sometime in just the next couple of years, really the largest growing segment of the TAVR market, and you can see that they expect that this is going to grow more than 5 to 6 times in the next decade. So as a result of that, we really have to be thinking carefully about leaflet modification. Now, if you use Vinny's app, you're going to be a lot smarter, and you're going to avoid a lot of these problems. But sometimes there simply are no solutions with valve positioning, and you need to modify the leaflet. This is the classical basilica procedure, which involves using an electrified wire in order to lacerate the leaflet, in this case of a surgical valve, but it can be done also on TAVR valves and can be done on native valves in order to preserve better coronary access even after placement of a TAVR device. The challenge with basilica, and we've been doing this quite a bit at my institution now because Jafar Khan joined us a couple of years ago, is that it's a cumbersome procedure. It has an awful lot of steps. It's complicated to do. So one of the questions is, can we make leaflet modification easier? One of the devices that is being developed for this is something called the Telltale system, which is basically a specialized wire that is designed for laceration of a valve. It's insulated along its entire length, and then there is just a very small area in the center which can then be denuded in order to provide the electricity. And so this prevents the need for other catheters going over the top of this to provide insulation. So it comes with a dedicated wire, which is really purpose-built, and then a whole number of accessories that make all of the procedure and just makes the whole procedure simpler and smoother. So this is something which is currently undergoing testing in the United States. And then I'm sure you've all heard about some of these leaflet-splitting mechanical devices and other approaches. This is the shortcut device, which presented its results at the EuroPCR earlier this year, which is a mechanical device, which is then advanced down across the leaflet, and then it's closed down onto the leaflet, and literally a blade is extruded, which then allows you with physical force to lacerate the leaflet, really trying to mimic what is done with the basilica procedure, but a simpler, less cumbersome, less steps device. We believe this is going to be available in the United States sometime in the next year or so, and I think this is going to certainly increase the use of various leaflet modification approaches for the aortic valve. There are a number of other devices that are in development. This one I think is very interesting. This is called the splitter of a company called HVT Medical out of Israel, and it really is a little bit like the shortcut device, but this one involves, again, electrosurgical leaflet excision. So this device is inserted and then clamped down onto the leaflet and then electrified, and that electricity then allows you to lacerate the leaflet and actually grab onto a piece of the tissue, which is then removed from the body. So you actually make a V-shaped lesion in the valve, and you can confirm that you have tissue so that you know that you've actually done something. So this seems to me to be a very interesting concept. There are other devices that are even more dramatic, I would say, but I don't have time to speak about them. Finally, new leaflet designs. Eberhard talked about this, the Dur-AVR from Annulus, which is a single piece leaflet that is biomimetic and designed to really replicate the flow patterns from the native aortic valve a lot better. The concept, here again is very attractive, but we don't know the long-term outcomes. But the hope is that this device will allow for better hemodynamics, excellent coronary access, really, sort of the laundry list of things that we all want. This is the first, the early feasibility study, which showed, again, with a mean annulus dimension of 22 millimeters, very similar to the SMART trial, for example, that the echocardiographic gradients with this balloon expandable device were on the order of what we see with self-expanding supraannular devices like the Evolute. This also, again, is something that Eberhard mentioned very briefly, the idea of a polymeric valve leaflet. I was sitting next to Vinny Bapat, and Vinny said it's not working, so maybe I should skip this slide. But it does seem like a very attractive idea if you can have a more durable device that is also non-thrombogenic, but I think this remains to be seen. Obviously, if we could have a very, very durable leaflet, all of these concerns about repeat procedures might go away or be diminished tremendously. That, again, I think is a holy grail for us. And then finally, Eberhard did focus on this, but I want to just spend a little bit more time on it because I think it's a fascinating device, which is the Siegel valve, which is, again, made of a different metal than anything that we've used so far. It's made of a rhenium molybdenum alloy, which basically is incredibly strong, incredibly resistant to recoil. You can see that the basic structure here looks like typical balloon expandable valves that we have today, but really the incredible part about it is that it can be delivered through an 8 French expandable sheath. Not a, so it's at least 2 millimeters smaller than any valves that we have available today. And again, as I said, really the magic of this is this rhenium superalloy, which is incredibly strong, incredibly durable, and has very little recoil. And so the idea of this device is it allows you to construct the valve frame with much less metal than anything else that is out there. This is the frame of the 26 millimeter device, just 18 cells. Compare that to the current cobalt chromium or nitinol cell numbers in our balloon expandable and self-expanding devices. And this allows it to dramatically reduce the crimp profile, has very open cells, which improves coronary access. It doesn't foreshorten at all and has minimal recoil and is very, very symmetric. So a lot of properties that we would like, and again, this is in early phase testing and hopefully will be coming to some clinical trials in the next year or two. So finally, I just want to summarize by saying that, despite more than 15 years of commercial TAVR, innovation in the space remains very active. I think it's really gratifying to see this. The areas of innovation are focused on the unmet needs and include TAVR for aortic regurgitation, novel approaches to leaflet modification, trying to make that a simpler, more democratic procedure, new leaflet and valve technologies, and then finally, I didn't have time, but Eberhard talked about it a little bit, about the idea of expanding where we're going to use these devices going upstream. Other promising areas that are, adjuncts are things like novel embolic protection systems and the use of artificial intelligence for procedural planning, which again, Vinny said he's working on. So I think we have to invite Vinny back next year to have him give another lecture and show us how far that has come, because I think that really would be tremendous. And finally, I would just say stay tuned, because the future is definitely bright for TAVR. Thank you.
Excellent, David. I think time is short, and we should probably turn it over to the next team so that they can go on with their live cases and discussion. So thank you all the speakers for excellent talks.